Good morning. Good morning. Welcome. For those who are returning for day 2, welcome back. For those who are here for the first day, welcome to our Arizona State University Nicholas A. Cummings Doctorate of Behavioral Health Program Conference. Our focus is, of course, on getting paid for doing integrated care. How do you generate revenue? How do you justify and demonstrate cost savings? These are the focus for our talks yesterday and even more so for today. I want to introduce our first speakers this morning. First of all, my name is Dr. Ron O'Donnell. I'm Director of the Doctorate of Behavioral Health Program. Our first speakers are Jeff Reiter and Lesley Manson. Jeff Reiter is co-author of the landmark book on integrated behavioral health care called Behavioral Consultation and Primary Care, A Guide to Integrating Services. And right now he's busy on a rewrite of that book and a new edition coming out sometime in the next 12 months or so. He works for Health Point Community Health Center in Seattle, Washington, doing integrated care for over many years now, almost a decade. He's done seminal work training and consulting, including work with Mountain View Consulting Group, training U.S. Air Force and implementing integrated behavioral health care worldwide. He serves now, I'm happy to say, this year as a part-time faculty member for the Doctorate of Behavioral Health Program. He also works for a consulting group, Primary Care Shrink, which helps organizations develop integrated behavioral health services. Our second speaker, Lesley Manson, is an assistant professor in the ASU Doctor of Behavioral Health Program. She also has spent 10 years providing integrated behavioral health care in all areas: quality improvement, clinical training, consultation. She has other different awards and recognitions. She was a former president of the North Coast Association of Mental Health Professionals in California. And she's still director of the Open Door Community Health Center in California, overseeing their integrated behavioral health programs. So please welcome me and welcoming both of our speakers today, Drs. Manson and Reiter.
Okay. Well, we can tell who was out late at the pub crawl last night, I guess, and who wasn't. People who come in about 15 minutes from now were probably out late. So I'm Jeff Reiter. This is Lesley Manson, in case you were wondering. And we're going to be kind of splitting up our talk today. She's going to be mostly talking during the first half of our time, and I'll be talking for most of the second part. And what we're going to be talking about is basically kind of an on-the-ground perspective of how do you grow and sustain a primary care behavioral health service. So if you're trying to make the case for a new integrated care service, what are the key components for doing that? How do you really make that work and sustain that? If you're in a service trying to grow it, what are the key ingredients for that? And we're going to be talking specifically about the integration of behavioral health services into primary care. So I know when people talk about integrating care, there can be lots of ways that they talk about doing that, putting primary care professionals into community mental health centers, so on and so forth. But we're going to be talking exclusively about integrating behavioral health into primary care. So Lesley's talk is going to focus mostly on the sort of direct revenue part. So sort of more of the kind of on-the-ground specifics and pragmatics of how do you bill, what are the different grant opportunities that are out there. When you are billing, how do you make sure your documentation is correct to support the billing? And then I'm going to be talking more about what we're calling indirect value of a service. And these are how to design a clinical model that makes your service a necessity. And help spur growth. And then we'll try to leave some time for questions at the end, although I will say we have a lot of slides, so we're either going to talk really fast or we might not have that much time for questions, but we'll try.
Very true. And on the board you see now is that we have very specific learning objectives for each of you today. We have the first learning objective of identifying direct billing codes. Kathy Reynolds discussed that yesterday as well, so I'll be reviewing some of those, some a little bit quicker than others. I'll give a little bit more detail related to the traditional psychotherapy codes that you can utilize in integration. We're going to identify specific examples of indirect value that behavioral health brings into primary care, and we're going to be describing appropriate behavioral health documentation for primary care.
So to introduce the topic of billing that Lesley's going to be talking about here, Kathy reviewed this very, very well yesterday when she was talking about all the challenges that come up for billing for primary care services. And this, we probably even left some factors off of this list right here, but fee-for-service is challenging in different places. There are capitated care systems that are in place or emerging. There are lots of state differences in terms of, and even county differences in terms of what codes are reimbursed, what licensure is required to bill for a certain code, whether you can bill for 2 visits on the same day, and so forth. And there are also a lot of differences in the private insurance sector in terms of what is going to be reimbursed. In addition, the kind of clinic that you're in can make a difference. If you're in an FQHC, the way that you generate direct revenue might be different from if you're in a private practice, for example. So we have to acknowledge, I think, right up front that there are an awful lot of challenges to billing for integrated primary care behavioral health. But given that, we're going to try to give you some ideas for how to work with what you have.
Thank you, Dr. Reiter. So far, hopefully, you noticed that with billing, it can be confusing. Lots of different issues can present, lots of challenges, but there's also lots of direction as well if you know where to look. So the first recommendation I always let people know is get started, get involved, okay? Become active. Reach out to the local state primary care associations, okay? Other facilities that are like you, that are already doing integration, reach out to them, review their billing codes. Look out to provide and receive very specific billing education, not only for you as a manager, director, or even a provider of care, but especially for your billers. There's direct education for your billers. It's highly important. Reach out to community stakeholders, collaborative or national organizations, and remember that most primary care state associations have toolkits that they put everything together for you. Manuals, documentation, billing code review for your state and related to each facility. Okay? Care pathways, different models for integration, step up, increased referral models, integrated behavioral health, co-location, reverse, all of it is typically within these toolkits. So remember that. Once you start to get involved, being active within legislation and moving that forward is also highly imperative. So remember that. Part of being a representative for your clinic is moving this forward so that everyone can succeed in the future. So the first piece of my talk is going to be about H&B codes, kind of the basics. Now I know Kathy did a great presentation yesterday talking about H&B, so I'll move through this fairly quickly because as Dr. Reiter noted, we have a few slides today, about 90. No, just kidding. I'll keep you awake hopefully for a little while. So the first piece is H&B. So I gave a brief definition of what H&B codes are there, okay? So hopefully you all learned that yesterday with Kathy. So it's really important that you also recognize who can bill for H&B as well, which is very confusing. All of that, again, with H&B is different per state, per facility, per insurance provider. Traditionally, across the United States, H&B are primarily reimbursable to psychologists working in care sites. Now, there are some few exceptions, which I will talk about a little bit later. Predominantly, I can say right now for the state of California, you have an exception for federally qualified health centers billing Medicaid services. LCSWs have the right to do H&B codes here. Okay? So please don't get confused and think that other types of licensure are able to do that. And I have that CF code later that you can read about why LCSWs are allowed to bill. And we have received reimbursement already for LCSWs in the state of California. H&B codes debuted in 2002. Again, just reinforcing what you've already learned from yesterday. It needs to be primarily related to the physical health. Okay? So the code will say used by psychologists, RNs, LCSWs, and other non-physicians with behavioral care scope. Some great references related to all the uses of the codes are down below. It's always nice to be able to look those up. And Daniel Brune's guide actually will go through step-by-step of your ability to even call your insurance company and how to talk to the insurance company, what questions to ask, and he also gives great recommendations related to how to increase your reimbursement rate. Okay. Here's the codes again, and we're going to go over them a little bit one by one. And I reformatted this presentation so you can see directly the documentation piece. part of one of my roles that have come up over the years within my facility and others when I do consultation is auditing. Isn't that a beautiful thing? Who in here loves auditing, right? Woo! Yeah, no. Yeah. I think when I do it, people are like, here she comes. But it's really important because it's really important to recognize what we do and be able to have that presence, okay? So for the 96150, when I'm talking about auditing, one of the initial things is about chart reviews. What are we writing, okay? How are we showing justification for our services? How are we talking to ourselves, the patient, and the providers, okay? So this is for the initial assessment. These are the pieces of information you will need in order to have accurate documentation to use this code. Okay? For 96151, for reassessments, and take particular attention to the first piece, significant change in mental or medical status requiring reassessment. You have to have that very specific statement documented and the reasons why in order for that code to be able to be reimbursable. Okay? 96152 and 96153. 96152, if you remember from yesterday, is your general one-on-one visit, okay? Follow-up visits. And the 53 code is for groups, which is typically 2 or more people in the group. Okay? You'll see, again, this definition. Now, I have to say that I'll talk a little bit later about some CAN statements and use of EMR systems. And with this first statement, you see H&B intervention procedures are used to modify psychological, behavioral, emotional, cognitive, social factors, okay, identified as important or directly affecting the patient's physiological functioning. Okay. This statement is something that is a CAN statement that is in every single documentation note for my employees that are utilizing H&B codes. Then they go on with the definition of what that means for that specific patient. But it's an important reminder because that is what you need. Those 7 items are the required documentation for the 96152 and 53 codes. So it's important to know that. And if you'd like this, these slides, you can always have them for reference later, which will help you. 96154, intervention with family. Okay. Now, no, you can only be able to bill an intervention with a family if you are able to document and identify reasonable necessity for the patient's family to be present. Okay. Now, family is actually well defined. Family members can be individuals that are part of their social support network that have been clearly defined as someone who is part of that person's care. Okay? It could be a direct biological family member, okay, or a partner of some kind. Now notice I do not have the next code, 96155, because that is without patient present. And normally in my experience, we have never been able to get that reimbursed. Okay? So I've taken it out. You're welcome to do it and try it, and then let me know. I'd love to find out. What I've heard is that it has not been. I also implemented documentation specifically that you can see. This is part of an EHR system, electronic health record system. This is my what we call smart phrase for documentation, which means that every provider that enters the code and is going to do a note for H&B has this automatically come up. There's drop-down menus that you don't see in here, okay? And there's some CAN statements that some of it I took out, okay? So it's really important to pay attention to exactly having the right documentation and utilize your EHR system proficiently. EHR systems can be a significant value. And lots of EHRs have these codes of being able to share documentation strategies. Just the other day, Dr. Kessler was talking about his documentation, and we know that we have the same EHR system. So we can actually share smart phrases. So I can see what his is, make sure mine is accurate as well, kind of share those things. That's important. That's great work when we can do that together. Okay? We're all building our practices together. H&B code basics. Federally qualified health centers, this is that ruling related to Medi-Cal and LCSWs. Okay? It's a great thing in the state of California we have. Unfortunately, I also know that in most states, this is not valid. Okay? Now, mind you, even when you read a rule, is this too loud? Am I okay, everybody? Okay. Even when you read a rule from state to state, oftentimes there's areas for interpretation. So always remember to reach out to your state organization so they can get clarification. One great thing is that I'm part of California Primary Care Association, which is a large state organization association which we represent almost 1,000 health centers and community health centers in the state of California. We're able to reach out to legislative groups, county, state, and federal organizations to ask very specific questions and sometimes get very specific answers. Sometimes we look at it and we're like, oh, I'm reading a politician answer. I have no idea what that says. Do you? No, I don't know. So it is important. Always utilize those strategies, those tools, and those people that are there to help you. Okay. Who reimburses for these codes in general? Medicare. Over 50 private insurance companies, most do. So remember that if you don't have same-day billing, you may not be able to do this. Another great confusing thing that happens in these states. Okay. And again, here's those slides. If you want these slides, these are part of the National Council for Community Behavioral Health Care, and these slides are accessible through SAMHSA. So at any point, if you want these billing slides, they are accessible through SAMHSA, and they give a state-by-state breakdown. Who can bill what? So in the state of California, we did a survey in 2012 through CPCA. In the state of California, for the community health centers and community medical centers that completed the survey, we had about 31% that said they were using these codes, the H&B codes, in integrated behavioral health. So you might think that number is fairly low. And that number also included sites that were only doing 15-minute or less interventions. Now, the reason why that code is low is also because predominantly in California, they hire LCSWs, okay, or MFTs, even though they can't bill for MFTs here, okay, for integrated care. So it is an interesting thing, and that's only because there's a lack of psychologists for being able to be at these facilities and difficulty with retention and hiring, okay, which we'll talk about. So direct revenue, one of the biggest things, traditional psychotherapy codes, and they can be utilized at integrated behavioral health. Okay? I've heard people before talk about, we can't use those codes, we're in integrated behavioral health. Yes, you can. Now, if you're going in and you're doing something that's directly related to diabetes care, and that's primary, then you're going to use H&B, whether or not it's reimbursable, right? Okay, we do the code that's accurate. But for most people, this is what they're utilizing, is the traditional psychotherapy codes. So we're going to go over those a little bit today. Okay? And in California, through that CPCA survey that we did in 2012, it stated that 74% of all of the clinics were utilizing traditional psychotherapy codes for billing and being reimbursed. Okay? So you can see that this is something that's happening everywhere. So I'm going to go over the new CPT codes. You should all be well aware of this, and if you are already billing, already know them and use them. If you're not utilizing these, then please, tomorrow, put your hair in fire and change them all. Okay? So the first code, 90832. This is the psychotherapy 30 minutes with patient or family member. Historically was 20-30 minutes. I'm actually going to show you what it is now. Okay? The new code, 90834, that's 45 minutes. And 90837 is 60 minutes. Okay? So notice you have these other little small times below. If people are familiar with these codes, you notice that I did say historically, okay, because previously we had these specific rooms, okay, of time. This is what it is now. And this is really important because that's the required face-to-face time to use these codes. Okay? I've had people before say, oh, my director is saying that I can use this code when I'm documenting. Okay? So technically, you're not billing for documentation. Okay? No. What you're billing is for face-to-face time. But if you had a 30-minute slot carved out and you spent 20 minutes with a patient, yes, you can bill for 30 minutes. Does that make sense, everybody? So there's the time span. You're not billing for documentation. However, there's fabulous research that's coming up, okay, and ongoing, and you can actually look at some of that research on NCHC's website related to completing documentation with the patient in the room. Okay? I've done it. I do it a lot. Most often when I'm in the exam room with patients, but there's lots of documentation on that, noting that there's improved patient satisfaction, understanding, and efficiency for both the patient and the provider, okay, the behavioral health provider. So that's an important consideration, something to consider, okay? Because who in here are providers? Anyone in here a provider of care? Who in here is like documentation is like the thing that haunts them? Anybody? Anybody? Or paperwork? Okay, maybe I'm alone in that. I see Dr. Reiter shaking his head. It's always there. I might work, my clinic might end at 5, but I'm there usually till 7:30, like doing work when I'm with patients. So that's important. Next thing, psychotherapy code should not be billed for sessions lasting less than 16 minutes. So does that mean that we don't provide interventions at less than 16 minutes? No, of course we do, especially in integrated care. We know for a fact that with 3 minutes with a patient can help them move through stages of change. There's lots of documented evidence on obesity, on smoking cessation, and other health behaviors. Okay? It's really essential and important. We also know that physicians can upcode, they can add extenders on their codes in order to just provide smoking cessation for 3 minutes. Now, Kathy referenced a little bit of those E&M codes yesterday, so I'm not going to go into them. If people had questions on them, I do have all those codes and I can talk to people about it. Okay? It is really important to consider that because as much as the amount to be able to add on for a physician regarding coding seems small, usually it's between what I've seen, $16 and $25. Okay? If you think about it in a year long, it can be very big. And you can actually go online and you can see the data from different sites of what they've done, and it can bring in about $30,000 a year, okay? Which in some budgets isn't much, but it's still money, okay? Documentation. So for traditional psychotherapy, what I often find in chart reviews is the problem of narratives. Narratives are no longer, please everybody. Most of your associations, if you're a mental health professional, have actually come out and said, stop your narratives. Okay? That is not something that they're teaching you to do anymore. And they haven't in many, many, many years. Okay? So please know. So these are the things that are important to have inside your note. Now I also have, I'm unable to show you what my documentation looks like on my EHR system, which are drop-down menus, some can statements, and fill in different areas. I'm unable to show you because it's very long. If people are interested, I'm happy to share it. For those of you who have been in some of my classes, you've probably asked or inquired about it, and I've sent it to you, okay? I'm always willing to share the documentation. And I do have specific verbiage that Medicare and other insurance companies require because of my work with them and my ability to be able to have that knowledge, okay, of what they require for audits. So you can look at these things. So some of the things to point out. There we go. Mental status, stereotypically, you're looking at only 2 aspects of the mental status that need to be documented. So just to let you know that. Obviously, diagnosis. Okay, justification for treatment. Extremely important. And ensuring that justification for treatment when you're inside a primary care office is also related to their health status. Okay? Also related to the primary care provider's work. Okay? Interventions, obviously. Response to treatment, progress and outcomes. Prognosis. Risks, risk assessments, and your plan, okay, your homework, your what's happening next, your agenda setting for the PCP, all of that's underneath there. Okay, that's what I put under plan. So in my plan, it's pretty long. Okay, one other thing that I utilize in my notes is scaling, okay, or use of screening tools. Screening tools are highly valuable. Oh, I got a question. Oh, I think I have to give you the mic.
Oh, I can speak up.
Okay.
The diagnosis, you said has to have a diagnosis?
Yes.
What kind of diagnosis?
DSM. Or ICD-10 or ICD-9. Yeah. Okay, psychological diagnosis. Okay. Must be primary. Okay. So we also use screening tools. That's where I was going with this. Screening tool. Yes, Roger.
One, is there anything on there that can't use drop-downs?
Yes, all of them. Most of them. Drop-down support, what I have is mental status. Diagnosis is already formulated in a chart, so it's somewhat like drop-down support, okay, because it's already part of the medical record. Start and stop times, okay, I can actually implement that in mine as well, and then we just change them if needed, okay. Interventions, we have a list. Prognosis, and risk and plan, both.
So how long does it take you to write that down?
Not long. For me, 3 minutes on average. For a new person, 10 minutes until they learn it, 15 sometimes. Okay, but 3 minutes on average for me. Not long. Not long at all. Yes. You there. Dr. Sue Papalizio, is that her name?
I was thinking about what you were saying about the billing time span and
Yeah.
constantly face-to-face. And this is something that Medicare has been really talking about for many years. One of the ways we figured out how to deal with this, like you said, you write the note while the patient is still there.
Yes.
And what I have found is, especially as we've gotten EMR and I'm typing, the patients
sharp? Did I get that? And then if I'm making a mistake or my interpretation is off or it's not quite what they said, they correct me. I find my note is better and my rapport with the patient is better and the patient is more satisfied with their session. So just something to think about. Medicare is happy because we're not billing for documentation, but the documentation is being done during billable time, which means the powers that are paying you are happy too.
Also, I just wanted to bring up the issues, the cultural issues, because sometimes I work with a population that's mostly Latino, and it's very important for them to have the eye contact, the handshake, the looking in the eyes while you're doing your therapy. And for me to be sitting there typing away isn't going to go very well over with the population I work. So, I mean, I try as much as I can to get some information, but, I think we need to consider the cultural issues as well.
Definitely. Oh, we've got another one. And to be honest, one of the things that we did in one of the rooms, now I'm someone that can type without looking at all. So I actually got a keyboard that was attached through Bluetooth. Oh, I'm double miking it. Attached through Bluetooth. Sorry. Attached through Bluetooth. And so I could sit watching the patient the entire time, looking at them in their eyes, typing. And now I was typing important things for myself to remember, important things to bring up with the patient, important things that they brought up to me, okay? So it wasn't exactly the note, but what was easy about it is after that, after I was done with the patient, I had everything really that I needed, okay? Quotes, everything, things to bring back to the patient, highly efficient. So there's ways and workarounds you can consider if you're going to do the in-room documentation.
Very small question.
Well,
Can you please tell me which version of the DSM you're using?
Oh, thank you. That's not a silly question. Actually, that's really complicated. Right? Oh, those challenges. Yay, the states. We love you all. No one's here, right, from there? Okay. So using the DSM-4TR, okay, for billing purposes as of right now, hopefully we will switch in October. What is it? October 4th or 14th or something, is the mandated switch. That is when we will. Now, who knows what, because the state of California put out a notice saying that they're not sure if they're adopting it. But they will. They have to. But that was when it first came out. So it was one of those things. I did all these great changes, was ahead of the time with my crew. We've got it. Had all the DSMs lined up, got them all in. Actually had my support staff tab all of them. Yeah, because I'm like that. So we actually had them tab them all, delivered them all to sites, did these great in-services, and then I was notified, yeah, you can't bill any of those codes. No. But what the recommendation is, okay, from APA and the states that I know, okay, this is what I know, is that you are to utilize the new criteria in 5, but code for 4TR. That is what I've been specifically told to do, okay? And so that's what I've been telling those, and to clearly document that. So just, oh, no, and you do, yeah, right? All these great challenges. Thank you. So there is a GAF. Medicare still requires the GAF. It doesn't exist, does it? Really? Oh, but we have to do it. Oh, I'm sorry. So Medicare does still require it as of right now. I have not heard otherwise. So we still require the GAF, and it's actually one of my drop downs. I didn't put it in here. Last night, Jeff and I were talking about it. I was like, damn that GAF. But so I don't have it in here, but it is one of the ones that is on my standard note, yes. Any questions? No. Good questions, though. Okay? Important ones. So going back to that, we're talking about drop-down menus, all of this. So those folks that are in here that are looking at management, that are part of healthcare exec teams, when you're looking at implementation or even sustainability, look at the EHR. Highly important. That's going to determine your billing flow. Okay? That's going to determine appropriate documentation and appropriate communication. We don't want to get 2 different systems that can't talk to each other, okay, or a system that locks out one person from another. Now I'm a fully integrated site, so everyone has access to the chart. I'm documenting in the primary medical record, okay? So it's fully shared. So it's an important thing to recognize and look at, okay? So why do we document? This is always a fun one, right? I used to say, you've got a highly aggressive lawyer on one shoulder and a highly anxious patient on the other. Now it's like, you've got a group in there. When you're writing and documenting, you've got the patient to think about, you've got the auditor, which we love. They're beautiful people. We've got attorneys, you've got the primary care physician, right? You've got other clinical staff, and you've got yourself or other behavioral health staff. Because not all behavioral health providers are going to see that next patient the next time, right? You might have one interchange with a patient, not see him again for a year. You might have one and someone else will see them next, okay? So moving through, direct revenue, another alternative. This is the new code from Aetna. It's actually a very old code from Medicare. Medicare utilized it for years, so did most of every single insurance company. Did we not know this years ago? What happened to that? This was the consultation code for people to be able to bill for behavioral health, kind of health coaching and very specific use of these kind of H&B-ish type considerations in the exam rooms, okay? So this has been around for years, about 10 years ago now, I think 2000 and something. Sorry, everybody, I'm on that one. 2003, perhaps. Medicare decided to let go of it. So you know what happens when Medicare says no? The whole crowd should say, everyone says no. So insurance companies just fall in line. So Medicare got rid of it, so everyone else got rid of it except for Aetna. Aetna still has it, okay? So here's the code. This is what you need, all these pieces. Now, one great thing about Aetna is they're also allowing individuals that are non-licensed to be able to utilize this code. However, they have to be able to be a provider of Aetna, okay? So it's kind of a catch-22 on that. How do you become a provider of Aetna if you're non-licensed? They can't answer that, but, you know, because I've had many discussions with Aetna related. However, you know, you can have a caveat where maybe the provider's billing and there's someone else alternative. These codes will be pulled from, I should say, sorry, before I skip, this reimbursement will be pulled from their behavioral health money in Aetna. So it is a covered service from the behavioral health plan, not from the primary care plan. Okay? So it's also an important piece to know. So you can bill the same day as a medical provider visit. Okay? But again, you have to have all these pieces in place. Okay? So moving on, because I know I've got to be moving on. We've got CPSP in California, which is for Comprehensive Perinatal Service Programs. Now, one great thing about this program is that most states have some type of perinatal service program embedded in their state. Okay? And now the funding goes through lots of different types of funding streams, Medicaid and carve-outs and other things. But one great thing about it is that this program allows you, for one, to bill for just education. And hopefully you all know in here you can't bill for education. Okay? But this plan allows that. Okay? So this is fabulous. It also allows you to bill for people that are unlicensed. Because I know that I have unlicensed behavioral health providers working every single day in my clinics. Okay? And they're unlicensed for various reasons, okay? And not because of competency. I had a DBH unlicensed in my facility, okay? However, they can bill here. So can other folks. So only providing very specific types of treatment, psychoeducation, social emotional assistance, health coaching, okay, health and behavior education, groups, okay, all to promote health well-being and ensure related to decreasing the rates of postpartum. Okay? These are all the different individuals that can become CPSP providers, and it's a very easy formulary to become a CPSP provider. It's not complicated, which is amazing, right, with that type of bureaucracy behind this thing. It's very easy. It's just some paperwork. Okay? So this is something that people miss. Okay? In our primary care offices, we also have obstetrics. So this is a wonderful addition. All of our women, we now have behavioral health providers there that can provide education one-on-one and in groups. Okay? So just, hold on. There we go. I did a little bit too much of my clicking. So let's look at this in another way. So outside of those direct codes, those direct reimbursement, okay, we're also looking at other ways to find money. Okay? One thing to consider is through grants. There's lots of grant opportunities out there, and it's really important to look at them. I gave you a number of them that maybe you can't see because I used the pretty color of red. Okay? I gave you a number of these that you can look at that have, all of them have had grants for behavioral health or integrated services of some kind. Okay? So it's very important to be active looking at these grants. Also recognize disease specific. Okay, team up, be creative. I think Kathy had mentioned that yesterday as well. Okay, I can tell you that every time my exec team gets together, we talk about like the grants that are coming up and who's assigned to what or how we would use it. I'm like, and everyone at DBH knows I raise my hand all the time. You know, like I'm like, oh yeah, that's right, behavioral health, what? Okay, it doesn't matter what the grant is. It's important that you look at how you can deliver those services through that grant. How you are going to be beneficial to meet those needs, those outcomes. Okay? No matter what it is. Look at that. Team up. Be creative with it. We were able to get funding related to some personnel, which you know is rare if you know grants, okay, related to behavioral health, with being able to use a food stamp program. Okay? So it's amazing what's out there and what you can do. And that was a rather large grant, okay? About $500,000. Okay? So be creative. Here's some more, okay? Look at your state associations, other stakeholders, team up, okay? Consider contracts. About 34% of the CHICs, as I was talking about before from CPCA, 34% have contracts with other organizations, other medical health centers, you know, and other sites, okay, community organizations, in order to provide behavioral health services or primary care services. And so those extra contract dollars can go into helping with funding as well. So business case for behavioral health. The cost of behavioral health employee. Anyone in here that's management, you know cost is pretty large. I always say it's double the salary, okay? That's what I say. Cost is double the salary. People always forget that because they think, oh, it's just their salary. You're like, no, it's the computer, it's their desk, it's the chair, it's the front desk person, it's the medical record person, a part of their salary, okay? There's a lot that's involved there. Oh, yeah, are you paying their malpractice? You know, let's just go on. Okay, so there's a lot of costs involved. Okay, there's also just the culture change, the vetting, okay, the new employee, okay, all of those things, adjustments. Okay. So it's really important to start to recognize that and look at it. Okay. For management, the other pieces to look at are things like, well, how many billable visits in a day, once I know my cost, okay, how many billable visits in a day will actually help to pay for that person? Okay. For me in my clinic system, okay, it's about 8.5 in the pocket money. Okay, like really I received it, not just billed it. Okay, we have 10 slots a day for our behavioral health providers and 6 extra slots. So that's a total of 16 per day. Okay, and so we're hoping to get 8.5 of that. Then that person is paid. Okay, not bad if you think about it. I also have to say I'm an FQHC, so I had to get a good PPS rate. Okay, on the PPS rate side, you can technically build in behavioral health into your PPS rate, especially non-billable, because it's kind of the wraparound services. PPS rates are kind of confusing if you're not an FQHC and don't know what that is. It's another reason why FQHCs can't bill for groups, because it's built into the PPS rate. You can only bill for one person in a group if you're an FQHC. Okay? Even if you have 30. That's always fun for billing. Every group, they have to go, wait, so I billed this person last time for group, now I'll bill this person, then I'll bill that person. It's always fun for them. Also remember for management, looking at screening and screening practices, universal screenings. In California, okay, 74% of CCHCs are utilizing universal screenings, okay, on an annual basis, and some of them obviously more often. Only 29% are doing it for children. But they're all out there. If anyone wants the recommendations of those screenings, I'm happy to give them all to you, including all of the screenings themselves. Now remember with the EHR tie-in with screenings, it's important for your EHRs and very valuable if your EHR has those screening tools embedded in them already. Some screenings are payable. Okay? So it's important to look at that. Could be an extra source of payment for you. Okay? So also consider what's in your EHR. When we switched to Epic, I had this great substance abuse screening tool that I was like, oh, I have to let that go because it's not an Epic. But that's fine because Epic had another good one. Okay, but we do have to make those changes. Okay? And it helps you because then you can have your own dashboards for not only the primary care physicians and how the behavioral health are working, but also for the behavioral health providers. If you don't know what dashboards are, I'm sure the management does. I won't go into it today because of time. Okay? Quality improvement activities of how behavioral health can be supported through quality improvement and management. Behavioral health providers bring an essential piece of learned communication, personality characteristics, style, okay? Personal style, right. They bring a lot to management, a lot of flexibility and ability that other individuals and professionals may not have. So they're great to be able to help out in lots of different areas of management as well. It's important to look at stakeholders in the community, what they're willing to provide, and then important to look at same-day billing for those of you that are in those states because of how much effect that can have on reimbursement. Uh-oh. I'm coming. Okay, I'll go.
I'm curious if you could give us some information on what the minimum average billable behavioral health encounters are at your organization, and maybe if you're involved with the CPCA, FQHCs throughout California.
Yeah. Technical question, because it depends on the cost. There's no minimum number. I can bill for 30 visits in a day if there's 30 unduplicated patients and providers. But it's the cost ratio. So how much is profitable?
I'm curious what your expectations of your behaviorists are.
8.5. I have 16 slots, but 8.5 is where I'll be good. Okay. So do people exceed that? Yes. Okay. I have, other people have. Do some people go under? That's a big signal to me of, are they really ready for behavioral health? It's high stress, primary care. It's a lot of changing if they're from traditional work. Okay. But 8.5 is the minimum that I've ever done.
Does that go for FQHCs throughout California?
No. No. Every FQHC has a different rate. Okay, I have multiple FQHCs. My rates span from about $120 to $165. That's whether or not I spend any amount of minutes with them. So that would change how many visits it is. So some FQHCs have a much lower rate. Okay, some people are billing and only getting reimbursed for $60, $100. It's very different. So you have to find out what yours is going to be. Okay. And plus, billing is all changing now anyway, which I'm not going to go into, but I'll get you a second, Paula.
Just a quick question. When you say the slots, is that 30-minute slots or?
Yes.
Okay.
Yeah. No, we don't do anything. We do not have anything that is over 30 minutes. I'm not saying you never do if there's something that happens, but then you're just going to see everybody else a little bit behind. Sorry. A lot of 10-minute, 15, 5s.
Thank you. Just one comment about the H&B codes. I understand that either 2014 or 2015, their work values will be reviewed. The work values for all codes are reviewed every 5 to 6 years. The problem is if it goes up, then something else goes down. So, but anyway, there may be more reimbursement is what I wanted to say.
Yes.
Are FQHCs exempt from using the PQRS system? Because I didn't hear you mention anything about that yet.
Do they have to? Yes. No. Business case for behavioral health. And I do want to say there's a lot more with reimbursement, but I know I can't get into it, and especially in the state of California because everything's changed, and everything is going to continue to change. Okay, Medicaid was carved out and sold. Okay, so now you have folks that are in different counties with different plans. It's about 5 different insurance companies now running Medicaid in the state of California. Each of them have a different plan, except for Kaiser, for behavioral health. Okay, so which allows you technically for same-day billing, but it's not at the federal level. So we've been told to go ahead and try it. What I said is let's try it for 1 month and then wait a year and see if we get the reimbursement, because that's how it goes. And then 3 years later they'll tell us to pay it back. No, hopefully not. Executive team benefits, okay, I'm only going to speak I'm going to actually have you read this so that we can move forward, okay? Lots of benefits to think about for behavioral health, lots of them, okay? And not all related to direct revenue and direct billing, or even always direct patient care. And I also have to say, people are asking about numbers of visits, all of that. I have integrated providers that they don't have a schedule. Okay? They don't have a schedule at all. They go in before the primary care provider goes in. They're part of the care team. Doesn't matter. I've gone in to see people that are coming in for immunization. Okay? And I have valuable conversations with them. Okay? So those folks don't have those visits. They don't have 30-minute slots. They go in all day. So there's lots of business cases for behavioral health, including even with retention. It's very difficult in primary care, and even wellness and staff motivation. Okay? So I'm going to go ahead and give it up to the esteemed Dr. Reiter to continue on. Thank you, everybody.
Did you say steamed or esteemed? All right. I'm good.
You sure?
Yeah, I'm just going to use this mic.
The mic,
Okay. All right, so before I get started on my part, which, as I mentioned before, I'm going to be talking about a clinical model for indirect value of an integrated primary care service, I want to tell you just a little bit about where I work. So, as Ron mentioned, I'm the director for the primary care behavioral health service at Health Point Community Health Centers, which is in Seattle. We have 11 primary care clinics, kind of all scattered around the outskirts of Seattle, and our behavioral health service started back in 2002 with 2 psychologists, and it's just kind of grown over the years. We've added round about 1 psychologist each year. So we now have a behavioral health staff that includes 11 psychologists, so 1 psychologist in each primary care clinic. And we also have a training program for predoctoral psychology interns and practicum students. So we have a little bit more than a 1.0 FTE behavioral health presence in each clinic. But there's a reason that I'm up here talking about the indirect value for integrating care, and that Lesley was talking about the direct revenue part. It's because Lesley is the director of the integrated primary care service at Open Door, which is here in California, which apparently has a more favorable reimbursement climate for integrated primary care. I'm in Washington State, which does not. So since 2002, our service has been in existence now for about 12 years, and we have never billed for a single visit in our integrated primary care behavioral health service. And yet we have grown, as I was saying before, from 2 psychologists to 11, including our training programs as well. So the question is, how does that happen, right? How has the service grown consistently over time when we're not bringing in any direct revenue? We have brother and sister community health organizations all around us who have tried to cobble together some billing. You know, they're billing for an expert code or something here or there, trying to piecemeal things, and they haven't really grown like we have. Certainly, a lot of our funding comes from grants, but a lot of our other brother and sister organizations have those same grants that have allowed them to would have allowed them to expand, but they haven't really expanded either. Okay, so. What I think has really helped us to grow as much as we have is the clinical model that we're utilizing. All right, and so this is a really important part if you're talking about either how to develop a new service or how to sustain one. Is building the right clinical model that is really going to build the momentum for your service. All right, it's what I call going from being a nicety. Your service going from being a nicety to being a necessity. The best way I can define what I mean by those terms is if I think about how a primary care provider is describing a service in each of these ways. So if a service is a nicety, here's how a primary care provider will describe it. If you ask them about what they think about their integrated service, they'll say, oh yeah, our integrated what's it called again? Our primary care behavioral health, something like that service. I think it's Maggie that works there. Yeah, she seems really nice. I think she's probably seems pretty helpful for our patients. Okay, that service that's described that way is a nicety, and in times of tough budgets, it's going to be the first one to be axed. Right? Now, a service that's described as a necessity sounds a little bit something like this. If you ask a primary care provider in that system. Oh my gosh, our integrated primary care behavioral health service, that Maggie is fantastic. I couldn't practice without her. In fact, I'm going to make sure I never work anywhere where I don't have somebody like Maggie. All right? So if you have a clinical model that makes you a necessity rather than a nicety, that's when you can thrive even in this difficult billing climate. So we're going to talk today about what is that clinical model. So a few common misconceptions. Now, all of these things that I have listed here, direct revenue, cost offset, clinical outcomes, these are all what I call kind of making a top-down argument for integrating primary care and behavioral health. These are things that are important, okay? They're very important for policymakers, they're important for administrators. They're not necessarily things that are going to generate a lot of excitement, though, at the ground level, okay? If you come in and try to convince an organization that the reason that they should develop an integrated service is because you're going to make them money, that's kind of a hard sell. I mean, most integrated services are, breaking even, maybe making a little bit of money. There may be some that are making a decent amount of money. But in all likelihood, you're never going to be a huge generator of revenue for a service, okay? So it is important to be able to make that argument, but it's not necessarily what's going to get you in the door and make you a necessity. Similarly, making a cost offset argument, saying, okay, there's going to be some initial investment for my service here, but you're going to get that all back. You're going to recoup those costs over time. Again, it's very important for us to be able to show that, all right, and be able to make this argument. But is this really what's going to take you from being a nicety to a necessity? Probably not. It's a little intangible. It can be a little bit difficult to measure. What about improved clinical outcomes? All this talk about, are we improving clinical outcomes in primary care if we're integrating? I mean, yes, it's extremely important, okay? We have to show that we're improving clinical outcomes down the road. And it's right there in the triple aim, right? But the reality is, again, and in the trenches, primary care provider, the ones that you really want on your side, this argument isn't necessarily all that important. In fact, it can be a little scary to a primary care provider. You know what a primary care provider hears if they hear that there's going to be a new service or a new program that's going to boost their clinical outcomes? What do you think they hear? More work. Oh, jeez. Great. Okay. Yeah. Now, I know it's going to be good for our patients. I know it. But instead of leaving at 7 p.m. now, I'm going to leave at 8 p.m. to go home probably, right? Okay, I can see how this is going. I mean, they are bombarded all the time with new programs and services that are, initiated that are perfectly well-intentioned, but that end up taking a lot of their time, okay? So these are all what I'm calling top-down approaches that help make the case for integration. And they're very important. It's very important to be able to make this case. But you also have to have a bottom-up approach, all right? You also have to have a clinical model that really draws in the people that are of the most value in this primary care organization. And that is who? It's the primary care providers, okay? This is what clinics really care about, is how can we build a service that's going to help our PCPs to meet their productivity goals and be more satisfied with the work that they do, all right? And if we can get to this point where the PCPs really see that your service is doing this, that your service is helping them to be more productive, to meet their productivity goals, and to be more satisfied and less stressed while they're doing that, then you've struck gold, okay? Now, why is this so important? Well, let me give you a little bit of... How many of you work in primary care right now? Okay. So maybe about half of you or so. All right. So primary care, especially in an FQHC kind of a setting, is one of those things that you kind of have to experience it to really get how challenging of an environment it can be to work in. So I'm going to give you a little bit of a flavor here for it. So this is an actual patient from a clinic that I was consulting with recently, and it just, when I was thinking of a patient, this one came to my mind. So this was a gentleman, late 20s, had just been released from jail. I was shadowing a primary care provider who was seeing this patient. It was her first time to see this patient. He'd just been released from jail, didn't have any insurance, didn't have any records at all. Came in and wanted his psychotropic medications. He said that in the past he'd been on lithium and Buspar when he was in jail. He wasn't really sure if they were helping. He knows that he's had several diagnoses in the past, but thinks there might be some others, but can't really remember for sure. And at the very end of this complicated, difficult 20-minute visit, the primary care provider asked, okay, so is there anything else? And he said, oh yeah, well I also have HIV. And so now this is a primary care patient, right? So this is a primary care provider who is trained to be a generalist, who has about 15 minutes, has already taken about 20 minutes to spend with this patient. Difficult. This is an example just from my own clinic. I was just thinking about the past 2 weeks in my own clinic, okay? In my own clinic, as I reflect on what's happened there, because even though I run the behavioral health service, the majority of my time I'm actually working in direct patient care. I'm in the clinic seeing patients all day long. So in the past 2 weeks, we have had a jam-packed waiting room. I walked out at one point, and every single seat was taken. There were people lining the outside of the waiting room, and there was a line from the check-in counter all the way back to the door, about 3 people wide. Okay, we've had so much PCP turnover. We just finally got 2 new primary care providers, 2 new front desk staff who were being trained, which is probably why the line was all the way out to the door. We were in the middle of a remodel, so we had about half of our rooms that could be used, but they were a little dusty, and then the other half was okay, but kind of old. And in the last 2 weeks, these are the patient events that we've had in our clinic. We had 1 suicide. We had 1 standoff with 8 police in the clinic and a patient in the clinic for 2 hours while the police were trying to figure out what to do with him. 1 person, we think, feigned passing out right in the middle of the lobby and feigned hitting her head, and that took quite a bit of provider time, time-intensive sexual abuse case, and a girl who was Spanish-speaking, and 1 subpoena, that's me, for a custody trial. So, my point here is that primary care is stressful work, all right? And this is all, bear with me here, because it's all taken me to an important point here about the clinical model, all right? But hopefully, you kind of get the picture that primary care can be a very challenging place to work. So if you look at the literature, there's a long laundry list of factors that play into stress among primary care providers. Many of the things on this list, if you look at them, you see them in the examples that I just gave, right, from the patient and from the clinic. It's not only primary care providers who are stressed, it's also the staff. Things tend to work that way, right? When the primary care providers are very stressed, the whole rest of the staff tends to also be stressed too. Okay? And all of this really does have consequences for the bottom line. There are both direct and indirect effects that stress has on these critical organizational measures. Absenteeism, quality of care, PCP turnover, all these things make it not only difficult to manage primary care, but it also really hurts the bottom line of organizations. PCP turnover in particular, it's a huge topic in primary care. If you think about all the costs that go into losing a primary care provider and having to hire a new one, it gets quite expensive, okay? So these are not just arguments about sort of the primary care provider's quality of life, but they're also arguments about how to improve the sort of financial bottom line of primary care, all right? So, what have we determined here? We've determined that primary care is a stressful place to work. We've said that stress can be costly to an organization's bottom line. So let's talk a little bit about how did it end up this way? Why is primary care such a crazy place to work? Well, it turns out a lot of it has to do with behavior. All right? So this pie chart shows a distribution of mental health and substance abuse care where it's received in the United States. So the blue piece of the pie there shows the percentage of people with a psychiatric or substance abuse diagnosis who seek care in primary care. About 21%. About 20% of those with a diagnosable substance abuse or psychiatric disorder will go to a specialty mental health clinic. Now, you also notice that about 60% of folks who have a diagnosable psychiatric or substance abuse disorder go nowhere for care. Okay? We'll come back to those folks in just a second. But what you can see right up front from the blue section of this chart here is that there's an awful lot of mental health care that goes on in primary care. All right? There's an awful lot of care for depression and all sorts of drug abuse, substance abuse problems, and so forth. And I'm sure most of you know that primary care providers provide the majority of psychotropic medications, majority of antidepressants, and so forth in the country. So just to start with, there's an awful lot of mental health care that goes on in primary care. But let's also think about that 60% that has a diagnosable psychiatric or substance abuse disorder who does not seek care for it anywhere. What's characteristic of those folks? Most of them, the vast majority of them, will enter primary care clinic at some point during the course of the year. All right? They don't necessarily come in for help with their alcohol problem or for help with their depression or what have you, but they're coming into primary care at some point during the course of the year for something. All right? Might just be a sore throat. But a lot of times, it's a lot more than that. We know that patients who have psychosocial issues are higher utilizers of care. All right? We know that emotional issues are a huge part of what drives people in for visits. Okay? But on top of that, it's not only mental health, substance abuse issues that drive people into primary care and that primary care providers have to deal with. It's a whole range of other behavioral issues that they have to deal with, right? So they have to work with patients on chronic disease management, how to make lifestyle changes for their diabetes, for their hypertension. They have to try to help folks who are coming in with somatic complaints that have a clear lifestyle or stress component to them, obesity, chronic pain, irritable bowel syndrome, chronic fatigue. These things drive an awful lot of visits. They have to work with patients on what we call subthreshold problems. So these are problems that aren't necessarily diagnosable, DSM conditions, but they're things that can drive a lot of care. So it's domestic violence, child behavior problems, bereavement, and so forth. Preventive health. Think about all the behavior change issues that are involved in preventive health, trying to get somebody to quit smoking or to practice safe sex or to wear a bike helmet, right? To eat healthier, to get exercising more. It's all about behavior change. These are things that primary care providers deal with all day long, visit after visit. Not only that, but because they're primary care and because they take all comers, they have all manner of psychiatric and substance abuse problems that they have to treat. All right? They can't specialize. They can't say, oh, I'm sorry, we don't treat that problem here. You take everyone who walks in the door in primary care and you do what you can, infants through adults. Okay? Unfortunately, they're really not very well trained, nor are they very well supported to do all this stuff. Okay? They get 10 to 15 minutes per visit. On average, 3 to 4 complaints per visit. Every time I say this, as I was talking about with Lesley last night, people in the audience say 3 or 4, it's more like 6 or 7. It's probably true, okay? But this is what the literature says. So 3 or 4 complaints on average per visit. Insufficient training in behavioral interventions. Do you know how much time in a typical family medicine residency is devoted to training in behavior change or mental health? One month. All right? And it's the month that, as my friend Kirk Strassel likes to joke, is when all the residents go on vacation. Because they all think that behavior change is not going to be something that they really have to deal with, right? And then they get out into the real world when they're practicing and they realize, oh my goodness, everything I do almost is about behavior change, okay? On top of that, there was a study that came out, some of you might have seen in the New England Journal of Medicine a couple years ago, that showed that in addition to their clinical tasks, or their direct patient care, I should say, PCPs have over 3 dozen urgent but unpaid tasks that they have to attend to on a given day. So these are things like, checking labs or reading through a report from a referral, or making a phone call to a patient, or calling a specialist. Okay, these are things that, in addition to seeing 20 to 25 patients a day in most cases, they still have these over 3 dozen other tasks that they really have to do that day that are urgent. And on top of that, PCPs really are notorious for really beating themselves up. And it's because they can never do as much as everyone is asking them to do, right? If a primary care provider tried to implement all of the screening and counseling interventions that's recommended by the USPSTF, it would take over 7 hours out of their day in addition to the direct patient care, all right? So imagine they're constantly being bombarded, telling you need to screen for this, you need to screen for that, you need to do this brief counseling, you need to, right? Okay, well, where do they get the time to do that? And as if the situation wasn't challenging enough with healthcare reform, we're probably going to come up at least 15,000 primary care providers short in order to really meet the needs. Okay? So, what are the implications of all this? Clearly, we need to integrate more behavioral health services into primary care. If we can see, as I've been talking about here, that behavioral issues are such an important part of the challenge of working in primary care, such an important part of the stress there, then it makes sense to bring a behavioral health provider into primary care, right? Okay? But there are more helpful and less helpful ways to bring that behavioral health provider into primary care. If you're going to join in primary care, you need to make sure that when you join, when you integrate, you do so in a way that meets all of these challenges, that really helps with all of these needs, okay? That doesn't add to the problems and the stress of primary care, but that helps with it. This is what sells people on a primary care behavioral health service, right? If you can come in and you can be a generalist, so you don't come in and say, well, I'm here to help you with all your behavioral health needs, but one thing, I don't see kids, right? That doesn't fly very well. There's an awful lot of kids that are seen in primary care, okay? You can't be a specialist if you work in primary care. You have to be a generalist. If you come into primary care and you are kind of off in the corner doing your own thing, nobody really knows what you do, you're not very accessible when they need you during the day, when they've got that patient who they've already spent 20 minutes with, and at the very end, they've got one foot out in the hallway, and the patient says, oh, did I mention that I have chest pain and that I'm suicidal? Right? They need somebody who can help in that moment, maybe not with the chest pain part, but with the suicidal part, all right? Take some of that time off of them. It doesn't do the primary care provider any good if they say, oh, you're suicidal? Okay, well, I've got a provider that you can see next week. You have to be accessible, all right? That means then that because primary care is a place where people work hard and they see a lot of patients, it means that if you're going to be helpful there, you have to see a lot of patients too. You have to have a high productivity. You also have to function as a part of the team. You have to provide team-based care. This is what primary care is based on. If you spend any time in a primary care clinic, you'll see all day long the providers are consulting with each other, helping each other out with patients and so forth. They're talking about their care plans, talking them through with people. You have to be that way too if you're working in primary care. If you're kind of functioning autonomously and nobody's really knowing what you're doing, you're not going to be contributing that much to helping out. You also want to be seen as a routine care component in the clinic, all right? Just a routine part of patient care. Part of what keeps a lot of people away from the specialty mental health care system is the stigma, right? It's sort of seen as this kind of strange, like, I don't know what this mental health clinic is all about. Why do I have to go there? What are they going to do to me? Are they going to strap me down? What's going to happen there? By contrast, you need to work at breaking down that barrier if you're in primary care. Just being there in primary care in and of itself doesn't necessarily break down that stigma. You have to be there, and the patient has to see that you are part of the primary care team. You're part of the chaos, as I like to call it. You're in the chaos, right? You're working side by side with the primary care provider. If you're going to be effective in primary care, you have to be a teacher. You have to help primary care providers to figure out how can they work more effectively with these patients, because they're always going to see more patients than you are. You're never going to get to every single patient who needs behavioral health help. So part of what you have to do is help the PCPs, primary care providers, to be more effective themselves when they're with patients. And then you have to use population-based strategies as well. All right, and there's a lot that goes into that, but it's an important part of being effective in primary care. Now, as I was saying just a few minutes ago, not all integration is the same. Yeah. Mm-hmm.
Very excellent list.
That's a good start. I like it. Thank you.
It's an excellent list. But one thing that I always say when I talk to people about doing integrated is, other than the patients, who are the most important people on your team? And I would say it's the MA, because they see the patient from the moment they walk in the door, the triage, they have the doctor's ear, they walk the patient out. And I have found that I have probably spent maybe 10% of my income on getting them little gifts and celebrating their birthdays, because they're more likely to call you if they like you. So love your MAs.
Good advice.
I would even add on that front desk. I can't tell you how much the front desk knows more about the patients than the providers do.
Absolutely.
Okay, it's all the way through the clinic.
Yeah, absolutely. I agree with both. Yeah, if you're really, it's part of team-based care, right? If you're really going to be effective, you got to get everybody on your side, and you got to work with everybody, and then they'll work with you. It's what they're used to doing. So, like I was saying, though, not all integration is the same. And so in Washington State, we have this group you might have heard of before. They do what's called impact work, and they get a grant to spread the impact model, care coordinator model, to 100 community health centers and 30 community mental health centers all across the state of Washington. It started in 2007 with just 2 counties, but then expanded to the whole state in 2009. Okay, so this is a program doing care coordination, impact work in 100 community health centers, mainly from 2009 till now. How many patients have they served in that time frame? 25,000 total for all 100 community mental health centers across all those years, 25,000 patients, okay? Now, in my own clinic, where we use a different model, we use the primary care behavioral health model, which I'm going to be explaining here in just a moment. We saw, our provider saw 8,000 patients in 2012 alone, okay? So our 10 psychologists saw 8,000 patients just in that's not total number of visits. Our total number of visits was around about 18,000, but our total number of patients was 8,000 in 2012 alone, all right? So my point here is that care coordination is a perfectly reasonable, it can be one perfectly reasonable approach to integrating primary care and behavioral health. But it ain't the be-all and end-all, all right? It's not. If you go into these clinics and you ask primary care providers, what do you think about your care coordinator service? Do you think they're going to see it as a necessity or a nicety? They're going to see it as a nicety if they even know that they have the service. I was talking to a primary care provider from one of our neighboring clinics, and I said, what do you think of this care coordinator service? And she said, we have a care coordinator service? And it had been in place for a couple years at that point. Okay, so that's a service that's a nicety. So the point is when you're integrating primary care and behavioral health, you want to do it in a way that really, really helps, right? And that it makes you a necessity. All right. So here's the outline of the PCBH model. We're not going to be able to go into it in a ton of detail, but suffice to say, the goal is to capture all of those things from that excellent list, as it was put by my friend over there, of this list right here. So the primary care behavioral health model is designed to meet all these things, to have people in the clinic who are generalists, who are accessible, who are seeing a lot of patients, high productivity, who are working in team-based fashion, and so on and so forth. Okay? Now, the behavioral health provider in the PCBH model, we call a behavioral health consultant. Why do we call them a consultant? Because their primary consumer is the PCP. So this is a hugely important point here. I spent the first 15 minutes of this talk talking about how stressed the PCPs are and how much help they need. So this is what we're trying to do in a primary care behavioral health model is have a behavioral health consultant whose main consumer is the PCP. Their job is to help the primary care provider to do their job better, okay, to work more efficiently, more effectively, and in a more helpful way. Okay? So these are the different dimensions that can maybe help to sort out a little bit what is the difference between a consultant versus a therapist, all right? Because you could be in primary care and work as a therapist, but it's going to look very different. There's people who work in primary care in what we call co-located fashion, often operate as therapists, okay? So it's a very different role from a consultant. So what's the difference? So as you can see, the primary consumer in a PCBH model is the PCP. If you're a therapist, your primary consumer is the patient or the client, okay? But our job as a behavioral health consultant is to help the PCP to have better outcomes and to work more efficiently and effectively with their patients, okay? You can read through these on your own, but hitting some of the other highlights. Termination of care. People always ask for follow-up. How does follow-up work in a PCBH model if you're a consultant? If you're a therapist, how does your follow-up work? You plan on following that patient until they're better, right? Until they've met all their goals or they're cured, however you want to put it, okay? But as a consultant, your goal is to help the primary care provider out. You follow along, and when the person is starting to show improvement, they're starting to progress, you back out of the care, and then they continue to follow up with their primary care provider, okay? And you're helping out, as needed, but you're not the main provider of the care. So why do we do it this way? Because this is what allows you to be accessible, right? If you are having hour-long visits and you're seeing the same people back week after week after week, guess what's going to happen to your waiting list? Longer and longer and longer, okay? But as a behavioral health consultant, you shouldn't have a waiting list. You're available on demand to help out. So let me give you a little bit of flavor of what this actually can look like. So this is a sample clinic day. It's actually one of my days that I charted out here. And so I'm going to go through it just from the first thing in the morning to the very end of the day to give you a feel for how this model kind of plays out. As we're going through it, look for some things, some key things. First is that there are a variety of methods that the patient is going to get to me, to the behavioral health consultant. Sometimes I'm going in before the primary care provider. Sometimes the primary care provider and I are seeing the patient together. Sometimes I'm seeing the patient after the primary care provider. There's a variety of problems and ages, and a variety of kind of tasks that I'm working with the patient on, and a variety in the goals of the visits. Okay? So it's all about, again, trying to help the primary care provider to do their job more easily and more effectively. It's building that indirect value. Okay? So 9 o'clock was 9 o'clock on my schedule was patient, 52-year-old homeless gentleman. PCP said, this gentleman came in to see me. I think he needs medications, but I don't know if he has a problem with ADHD or bipolar disorder. Can you help me kind of sort it out? They wanted input about a medication recommendation. Okay. 9:30 was a 64-year-old Russian-speaking woman. We use an awful lot of interpreters in our clinic. We have a lot of different languages that come in. So as a Russian-speaking woman, had a question about her disability expiring. So in this case, I was kind of doing some administrative work with her, trying to help her, some case management work almost, kind of helping figure out what we can do to help her. 10 o'clock was a patient who the PCP said, I don't know what's going on with this person. Can you help me out? It was the first time that this woman had been seen by the PCPs, had been seen a psychiatrist, but the psychiatrist stopped seeing her for some reason or another. She was on 3 different medications from 3 different doctors. PCP needed some help figuring out what do I do, okay? 10:30 was an originally open slot on my schedule, but turned into a WH, which is a warm handoff, with the PCP in the exam room. It was a 12-year-old who had these problems, and the PCP said, hey, I see that you just had or that you have an opening right now. Could you come in with me to see this patient together with me, and we can kind of put our heads together to figure out what we can do to help. 11 o'clock, I had a no-show. That's the NS. So had a no-show, and so a different PCP grabbed me and said, hey, I've got a 6-year-old who's coming in for ADHD and insomnia and enuresis, and I'm running really kind of behind. Can you go in there and kind of get started for me and get a plan going? Right? So went in before the PCP, in this case, did what we call PCP prep or preparation. 11:30 was a planned follow-up from a week earlier. Lunch, 12 to 1. 1 o'clock was a team meeting. 2 o'clock was I had a cancellation that turned into a patient who had walked into the clinic and said he wanted some help with smoking cessation, needed a refill on his nicotine patches, and they put him onto my schedule. 2:30 was originally an open slot at the beginning of the day. That turned into a warm handoff. One of the PCPs saw that I had that opening and said, hey, I need you to do a controlled substance agreement on a patient that's taking opioids or something like that. Can you do a controlled substance agreement with them? Sure. 3 o'clock was a planned follow-up. 3:30, another planned follow-up. It's kind of partly clinical cases, partly administrative case management kind of work. 4 o'clock was a cancellation, which again turned into a warm handoff. A 16-year-old patient had come in, he'd been expelled from school, and the school said they needed a risk assessment in order for him to be able to return to school. So the PCP said, can you help me out with this? I'm really running behind here. If you could get in and get things started or even do this visit for me, that'd be great. All right? And then 4:30 was an open slot originally, and that turned into a same-day follow-up, somebody who walked in wanting care. Okay? So that's sort of a sample clinical day, right? And what I hope you notice, I'm not saying that's a typical day or it happens every day like that. It commonly looks like that, but but I hope you noticed as we were going through that the goal is to really help the PCP to get through their day a lot more easily and to help them with all these different issues that are coming in. Okay, so so that's all part of building the making your service into a necessity. Right? Now, does it work? Well, so you can look at if you go to the USPSTF website, one of the things you'll notice is that there are all sorts of different models and that have added some sort of behavioral component to primary care as usual. And guess what? They pretty much always help. All right? It's really not hard. I know Roger's probably going to bristle back there when I say this, but it's really not hard to improve outcomes in primary care. Are any of you primary care providers? Yeah, okay, right. So, it's pretty crazy. And so it's really not hard if you do almost anything. Even if you teach a PCP to do a 2-minute intervention on around smoking intervention, it increases the likelihood that a patient's going to quit smoking down the road. Okay, just 2 minutes, 2-minute intervention. So in this kind of environment, it's such a challenging environment that really most interventions tend to succeed. Regardless of the model. There was a review done back in 2008 that basically had this conclusion said, look, adding behavioral component, no matter how you do it, it seems to help. It's not really clear, like that one model gets better outcomes than another. So what's most important to me is it is the clinical outcomes. All right, we have to show that we're improving clinical outcomes. But what's really most important, since that's not all that hard to do, what's really most important is how do we get those clinical interventions to as many people as possible, right? Because primary care is overrun with behavioral needs. So the question is, the primary question isn't really how do we improve care. It is important, but the primary question is how do we get that improved care to as many people as possible, all right? That's where the model comes in. It's really important. There have been clinical outcome studies that have been done on this model, and you'll have these slides. You can certainly, it's actually really interesting to read some of these outcome studies. They found some great stuff like, this first study that I reference here showed that patients with more severe impairment at baseline improve faster than those with less severe impairment. I see that all the time. I don't know about you and the rest of you in primary care who see this. You get people who come in with a laundry list of complicated chronic problems, and they respond pretty well, pretty quickly actually. Then you have these other people who are kind of mildly depressed or anxious and they sort of linger on forever, coming into the clinic over and over again. Right? But anyway, so it's an interesting literature to look through. But there is clinical support and it's a model that's been disseminated to a lot of different organizations. I'll call out Bill Rosenfeld's organization back there, Mountain Park, and Cherokee Salutes, a lot of large CHC organizations. This model is now the standard of care in all branches of the military. So all primary care clinics, Army, Navy, Air Force, they all are required to have utilize in their primary care clinics a PCBH service. Different business of the VA, a little bit less common in private for-profit organizations. The whole billing thing comes up and is a problem there. There's a large study underway in Oregon right now, actually, looking at the cost savings that accrue if you implement this model in a primary care clinic. Okay? And just a little bit of data from my own organization in terms of how providers perceive this service. And again, this is what it's all about, right? This is the important part about building the support for a service, is having a service that the providers not only think is nice, but that they think is crucial. And so you can see the providers in the organization talk about how having this service improves their job satisfaction. They feel like they're better able to address behavioral problems. They recommend the service for other sites. And they say they're more likely to continue working with HealthPoint. They're able to see more patients in their allotted time frame. All right? Patients actually love it too. people who aren't familiar with this say, well, but patients must hate that. Don't they feel rushed? 90% of in our system, 90% of our patients say the visit length is just about right. You know that 10% that say that maybe take some issue with the visit length, a lot of them say it's too much. It took too much time. I mean, these are people who are coming to primary care. They're not necessarily expecting, an hour-long therapy visit or something. So they're expecting brief interventions. All right. So, just as a conclusion, we just want you to keep in mind that there really are two really important components to building and sustaining a service. The one is the top-down. All right, it's showing that you can improve clinical outcomes, that you can pay for yourself, or maybe even generate revenue. All that's extremely important. But I've seen many attempts at integrated care programs fail because they're only built from that top-down approach. I just was at lunch with somebody yesterday who was saying, she was in the unfortunate situation, was just starting a new primary care or a new integrated care service in a rather large FQHC organization, and she was saying, I don't know, I think the administration kind of forced this on the organization. They decided that this was something that they had to do, and so they're kind of trying to force this on me. Okay? And she was really struggling with how to make this work because there was resistance. Okay? If you take only a top-down approach, I've seen a lot of organizations really struggle with developing their service. But if you complement it with a bottom-up approach, you have the right clinical model that really generates that support amongst the PCPs. That's the perfect complement, and you can build a service that really works. So, okay. Now, no cheating on these questions. Can't talk amongst yourselves. So that's it.
So let's give a thank you to Jeff, and then we'll have some time for questions. So any additional questions for folks? Yeah.
This is really a question, I think, for the program and conferences like this. It's really encouraging to have you come up here and talk and kind of have a visual of where behavioral consultants fit in primary care. I was at a conference, Medical Wellness Association, and they had a lot of doctors at this conference, and they were talking about really integrative care, but going more in fitness and exercise and how to get more fitness people working with primary care physicians. What are the opportunities of having more primary care providers coming to these events? Just so, we know that they're out there and they're connected, because when I mention this to them, they think it's a great idea, but they haven't, it's like they don't know of myself or...
Yeah. It's a great question and a really excellent point. And, I think all too often when we're talking about integrated primary care, behavioral health, it ends up being a group of mental health people talking about integrated primary care, behavioral health. And you look around the room and it's like, okay, I got the behavioral health part of the integration, but where's the primary care part? I mean, we had one lone PA raise his hand out there as the PCP. Thank you very much. But, we really have to do more reaching out. I mean, this is really an interest of mine, too. We really have to do more reaching out, more presenting at, family medicine conferences and things like that. And, yes, Roger.
So there are two meetings in which that's happening more. Not enough, but more. One is, it's being recorded, I have to use this. One is American Academy of Family Physicians has a meeting called the Practice Improvement Conference. That happens in the fall sometimes, I think November, I'm not exactly sure. The second is there is a group started by essentially family therapists on the behavioral health side, called the Collaborative Family Health Association, CFHA, which has an annual meeting also in the fall, at which the representation of primary care clinicians is a whole lot higher. So the AAFP meeting is primarily primary care physicians who are interested in quality improvement. And the chair, for example, of that meeting this year is a psychologist, Dan Mullen. So there's going to be a whole lot in that meeting. On the other hand, the CFHA meeting is primarily behavioral health folks, but with an increasing proportion of primary care physicians.
Yeah. And I might add, we have just started within CFHA a special interest group that is focused on the PCBH model. So Chris Hunter and I are co-chairing that group, and if you're interested in being a part of growing this model more, disseminating it, researching it, training people in it, and so forth, I would really encourage you to consider joining CFHA and join us in the SIG. It's gotten off to a fantastic start, and it's going to be a very active group, and we really look forward to the work that we're going to be doing with this. And if you're not a member of CFHA right now, it actually only costs $100 to join in your first year. So really check it out. The website is www.cfha.net. cfha.net.
I'm going to just key in one more time, and then I know we've got some more questions as well. So another thing that you can do, especially if you're a behavioral health provider, is you can become certified to provide AMA continuing education credits. Okay, that's what I do through my facility. I go through to IPAs. I provide continuing education, health coaching education, motivational interviewing for physicians. The only people in that crowd are physicians when I'm there talking. Okay, that is it. Okay, so it's a great thing to consider doing. You can become certified. It's a great benefit to your clinic systems. So it's another avenue to be able to reach out to those providers and have them be present. Okay.
Yeah.
I work in a primary care clinic, and our mental health and primary care clinics developed an agreement for medications. We initiate the medications, and then once the patient's stable, they're supposed to go back to the primary care physician. Well, there's a lot of resistance. So to combat that, we've hired a psychiatrist for consultation, and also psychiatry techs to call the patient to check for adherence and side effects. But there's still a lot of resistance, and this has been going on for at least 6 years. There are some physicians that will do it, others won't.
Yeah. Well, what that is a great example of is that patients don't always do what we tell them to do.
What?
I know. Shocker. I've been researching this.
That's not
true.
true.
I can tell you, they don't always do what we want them to do. But all kidding aside, there's a really important point here, right? Because we are constantly, when I say we, I mean we healthcare professionals, are constantly developing these systems that forget that. We constantly are developing these systems that assume, stepped care programs and this and that. We assume that patients are just going to go where we ask them to go, when we ask them to go there, and the reality is the vast majority of them don't, right? So I think it's really important that what we try to do in primary care is we try to capture people when they're in primary care, The more things that you ask people to come back for at another time or to go off somewhere else for to get, you just don't have a lot of success with that. But so, obviously primary care is, embarking on this grand adventure in the PCMH, right, the patient-centered healthcare home, and what a lot of that is all about is how do we get more services to patients while they're there in the clinic, because that may be your only shot with a lot of them. Okay, so I think so I hope as you all are going out and thinking about how to integrate and so forth, just keep in mind the more planning you're putting into how to direct patients here and there, the less likely your patients probably are going to be to follow your plan. All right, focus on capturing people while they're in the clinic and doing the most that you can with them while they're there, which means being accessible and so forth.
You just talked about patients not doing what they what we want them to do. That's absolutely true, of course. But the issue here, too, is that when we look at outcome measures, it seems to me that there are an awful lot of patient-related variables that we do not control. But when we display the data regarding outcomes, we say, well, we're 80% successful, or we're 75% successful, or we're 50% successful with certain population groups. No one ever much talks about the fact that all the elements that patients bring to that outcome, or whether or not an outcome is achieved, a positive outcome is achieved. Then you combine that with the fact that in a behavioral health setting, assuming that there are different behavioral health providers with different types of therapeutic backgrounds, clinical social work, MFT, counseling, psychology, DBH. Well, right, exactly. Mm-hmm. And that we see the patient through a different lens. So you take an LCSW and an MFT in the same primary care clinic, they may actually approach that problem or even recognize it differently or diversely in some way, and that affects an outcome as well. And I don't know how to standardize that. It seems like primary care is way more standardized than behavioral health care applications are when you consider patient outcomes. And I don't know if you have an answer to that, but I think that's something we ought to consider.
Oh, I have a great answer, but we're out of time. So, sorry. Yeah. No. Although, actually, we are out of time, probably. But, yeah. But, I mean, I think that in order to... in order to work effectively in primary care, the one thing that you have to do is you have to be a generalist. I mean, you have to just have a basic foundation of generalist skills that allow you to work with a broad variety of problems, because nobody is going to be an expert in everything that walks in the door, right? So, because one visit, you saw the diversity of problems, right, in the day that you can work with. So you can't be an expert in all that stuff. But we do need to be training providers in all the professions who have strong generalist skills. Because, but that said, there probably is always going to be a lot of variety in how individual patients are handled when they're in the visit, like it or not. It's certainly the same in the specialty mental health care world. You're right,
I just wanted to add on a couple things. One thing to let people know is that in my facilities we do a lot of telemedicine. So I do have telemedicine codes. It's an extra GO code add-on. So if people are interested in that, we also have added behavioral health telemedicine that comes in to provide services in the direct language for our other speaking populations. So that's an add-on that we've been able to do at our facilities. And for some of the added-on behavioral health services, there's zero cost for us to do that. USC has a great program, and they're providing that service for free through telemedicine. So just wanted to let people know that. If people would like information on that, I'm happy to give that. The other thing I just wanted to say briefly is that there's lots of ways to use your behavioral health providers. I did talk about direct billing, but please know that I have lots of behavioral health providers and lots of different manners and ways that they operate in the clinics, and that's not always related to the productivity of direct billing, rather productivity of patient access and improved care. Okay, we do a lot of population health management, and when we do population health management, we build it from the front desk on out. And when we roll out population health management, everyone is involved in the clinic so that we have improved retention and satisfaction, everyone, because everyone's role is important. So thank you all for putting up with us for an hour and a half.